We have an agenda today, a loop based on our best ideas, and we may at some point have a special guest or not. It's like really we don't know. We don't know. We have no idea actually.
Right. Okay. Welcome to the Health Tech Talk Show, where interoperability meets a budget operation, with the world famous host, the capitalist queen herself, Kat McDavitt. And our Share Bear socialist, Lisa Bear. So sit back, grab a drink, and enjoy your end of week roundup.
It's Guantanamo. So Lisa's not a socialist. We're worried. We're not going to say that because we actually are worried she'll get sent to the camp. So she's not. Welcome back to the Health Tech Talk Show, America. It's 2:00 Pacific time.
I get in trouble because you say stuff. Everyone remember it's all allegedly, like not allegedly.
Welcome to our new guest.
Quite a welcome.
Okay, listen. So we have like an epic person on the talk show.
And I washed my hands in the ladies' room next to Judy Faulkner, and we had a little chat. Yeah, just so you know.
It was incredible. Lisa signaled me about it. It was a signal-worthy event. Yeah, she had to let us know. So that's a great intro to our special guest. So we got a bunch of guests. Yeah, we got a bunch of guests, and we got this guy Seth. He's from Epic. He doesn't have a title.
Correct.
Apparently, they don't have titles.
They make up their titles. They make up their titles.
Every conference we get a different one.
So tell me what
whatever we want each conference.
What's today's title?
We have at least 5 fans who are dying to know.
King of the internet. We're on. This is the internet, right? That's what you described it as. The room we're in.
It does appear
is
that
the
way.
Internet.
Don't you think?
Let's see if
Kings and queens of the internet.
Let's see if his handler is okay with that title.
Hey, Jacob, what's his title?
Just give a hand.
Sure.
Okay,
Sure.
King and Queen of the King of the Internet. What'd you say? Anyway, okay, all right.
There we go.
We took a little nap. We had a little bite to eat, so we're back at it. So, Seth, what do you do if you don't have a title?
What do I do? So, I work across our R&D teams, particularly building out the foundation for our applications. A key, right, is from day one when Judy, who washes her hands in the bathroom next to you.
It's important.
Important that people wash their hands. If it would be worse if you were like, "Oh, she didn't wash her
Right,
hands." She did.
Good.
She did. Very good.
She also.
Your handler is even more upset now. No, we think she's great. I know, but I'm just,
Okay, keep going. Keep going,
I
Seth.
love it. All right.
King of the internet.
What do I actually do? What do I actually do?
Yeah, a foundation, platform. I heard all those words.
No. The key is that the apps work together, right? If the apps work together, people save time. And if you build a foundation that supports those working together, then clinicians can be happier. They can have more time with the patients. It's easier on the operations side. And so I spend a lot of time thinking about how do we embed analytics? How do we embed artificial intelligence? How do we make sure that the system is highly reliable and build that out so that all the applications don't have to worry about it? They can spend time focusing directly on the users that they build the software for, and those teams then go and build it. So that's where I tend to spend time.
Reasonable.
When are you going to acquire a bridge?
Are you familiar with the commandments?
Yes, we are familiar. Don't get acquired. Don't acquire.
Yeah. One.
Don't get acquired. Don't
Yes.
acquire.
So I think the answer's there.
Okay, never. Okay, that's fine. They seem nice. They seem like nice people. Okay, what is your favorite application to embed?
Who's my favorite? Oh.
Good question.
What is the most exciting thing?
The most exciting thing to embed right now is certainly the layers of artificial intelligence that are happening. Everybody says that, right? The AI. Everybody's talking about the AIs, and then they start, and then now this year they're talking about the agents on the AIs, right?
Shit. I haven't heard about that yet.
You haven't heard about the agents?
You've heard about the agents?
Yes. Yes, I have.
I only read the news Lisa sends me, so.
There's, the agents are the next thing.
They're doing stuff.
But it's just another integration layer, right?
Okay.
It's a new way to make the applications work easier together.
Yeah.
And to help, whether or not you want to spend time on outpatient, or if you can connect that, say, you asked which one of the teams I spent time on that I think is absolutely fascinating, right? So I spent time, this was working directly with end users on our dental application, Wisdom, right?
I actually did not know that Epic has
Yeah,
a dental
it's called
application.
Wisdom.
So that's interesting.
Seriously?
Wisdom.
Why does that surprise?
Yes, that's the whole point.
So fun.
See, you got it.
So fun.
If one thing,
got it.
one thing Epic
So-
is good at is like quirky naming. Quirky naming. Got it down
And
pat.
you get it. You get it immediately, and it goes on. It works in both
I just
directions.
always love that you guys have fun. Like most companies are like, this is our dental application.
3, 4, 5, 7.
Version 1.2.72.
How many companies data warehouse can you name?
Shit, I don't
know. I don't pay attention to that.
Did you growing up happen to have a very brightly colored makeup kit by
No.
chance? As a
I
kid?
wasn't allowed to wear makeup.
I
Neither
was
was
not-
I wasn't allowed to
yeah.
wear. I grew up
No,
Did
we
any of
grew,
your
we grew up on
friends
like
have one?
farms. Yes, they did, and I was
What
very
was it
jealous.
called?
No idea.
You organized a number of things in it. A caboodle.
A
You
caboodle.
got it. A caboodle.
Aw,
Do
Do you
you?
make caboodles?
we were like
Yes,
Amish growing up,
caboodle.
just to be
The
clear.
caboodle
That's actually
is
a
the
name,
name of our
Jesus.
data warehouse.
I don't spend a lot of time. I don't have any HR. Okay. Anyway, okay. Tell me about Wisdom and how exciting that is.
Well, no. So the point being
Oh my God.
that a lot of the data that comes from the dental office, even from a toothbrush,
Goes to the caboodle.
goes to the caboodle.
We gotta get our shit together. Okay. All right.
It
Goes to the
does.
caboodle.
It does. It does.
Goes to the caboodle.
And then, but it informs everything from population health, right? Your gum health helps everywhere downstream from helping manage populational perspectives, care management outreach, helps with your physicals when you go in on the outpatient side. So by having an integrated suite and then using that data signal throughout, you're able to both help provide better care, bring better information to the physicians and to the patients, help with follow-ups, those types of pieces. So yeah, I spend time on making sure that both that data flows, but then these new types of technology can be built right into the application.
Okay. What about, okay, so especially when you're talking about integrating AI tools at various stripes, a lot, these are health systems, hospitals who are taking this up. What are you thinking about when you think about helping your customers with governance of those applications and that data? Because as you know, the US government has kind of said like, well, we may not be doing that. And so really where it's happening is every single individual health system is like, what do I do? How do I do AI governance? I'm going to put together a consortium, a panel or whatever. Like, how are you thinking about helping them or not helping them?
No, it's a really important topic. So I tend to think about it in a few key phases. The first one is there's generally a common pattern as folks put out either a predictive model or use one of these generative AI models in the types of questions they want to answer up front, just early evaluation. So you can make that available to them to do the research, to have that understanding up front, just kind of cursory, do I have a sense of this? We call these, suddenly I'm blanking on the terminology.
Caboodle.
It's not, you can access it from the caboodle, but it's essentially a model. It's a model description, right? So you start with that, but then the second piece is you want to run that silently behind the scenes. So because each system, I grew up in Nebraska, right? You ever been to Nebraska? Either of you?
We have spent a lot of time in
Where-
Omaha and surrounding areas.
Yeah, I fly often to Omaha.
Okay, so you know how well populated Omaha is.
So much.
So many
It has a
people.
little bit of a different population than here in Las Vegas. True statement.
True.
But it even has a significantly different population than a hospital in Western Nebraska. Right? So and it's not just that the people that are cared for are different and have different traits and circumstances.
Different laws, different preferences.
Different laws, number of different things, but also the way that the workflows within the hospital work are different. The number of nurses they have is different. What the expectations for them are. Are they doing virtual nursing in some of these circumstances? So you want to be able to measure the algorithm locally. You want to understand it on the population. You want to understand it in the market. So we allow the algorithm to run behind the scenes. so you can get a sense in your local system. You can use that information then to determine how you want to put it into practice.
What you're
And
saying,
then
allow
use
them to
those
run
same
locally,
tools
like federated, like on their
on their
site with
system,
with
on their
their
s-
data only,
correct.
not with. Okay,
Correct.
that's a
Correct.
distinction.
That's
They're
an
like-
important
I think it's like
aspect.
client first. Client first, always on budget.
Yeah.
That's me too.
There you go.
The budget's
There you go.
high. The budget's high, but they're on budget.
And then from there, you use those same tools then after you get it live so that you do ongoing monitoring, because things change over time and you want to be able to account for it. So last year, we open sourced something called the AI Trust and Assurance Suite, which is a consistent set of open source tooling so that as folks are doing that workflow I just described from a governance perspective, and say an academic institution comes up with a new improved methodology for doing that evaluation and doing that monitoring, they can bring it into the open source tool and folks can start running it on their local population, continue to build up the governance. We're building, as we build algorithms, we build under that same platform so they can do it. So, sorry, a long answer to your question, but I think it's an important topic because both one, the rate at which these new technologies are providing value and are becoming available for folks is faster and faster. And how one can establish just a rapid methodology for moving through that, having trust both in what is coming and what's out there is key. And then being able to collaborate with the community. So,
Yeah. So what are you doing here besides you were told to be here? I mean, not this place specifically, but HIMSS. Like, what's the plan for Epic at HIMSS? Like, what are you doing here?
what are we doing? Well, there's
Small
always,
EHR company like you, really put your necks out there. Big,
Yeah.
I think one of
Big
the
risk.
Big risk.
one of the challenges is there's a number of things we've been doing across the suite, and it always starts with directly to the patient, right? So we've been spending a lot of time on making it easier for communication with patients through MyChart, and that includes obviously you're on the go here in Vegas, being able to use MyChart to communicate with your care team, but it also includes when you're in, hopefully not, but in the bed at the hospital, being able to use it at the bedside to communicate back home, being able to communicate with virtual nursing, those types of things. So that platform is something we're talking a lot about. We're also spending a lot of time talking about and sharing with folks how they can use the system to excel operationally in regards to capacity management, be that in the inpatient setting, be that on the ambulatory access side, and being able to have visibility through the data and the analytics into how to make those changes in real time. And we've been doing more work directly with organizations through our ongoing services, work with those folks to be able to use those tools more and more in those contexts, so spend time there. And then, as you might expect, we continue to put a lot of focus into advancing kind of the state of the art around how to embed analytics and AI into workflows. So you see that with Cosmos, which has now reached 300 million patients.
We like the Cosmos.
You like the Cosmos.
Oh, you don't like it?
I mean,
I do. I love it.
Have you noticed
I'm into it.
keep watching C's in regards to the
Cs.
names of the applications.
Cosmos.
Chronicles was the original
Chronicles.
application.
Oh, man.
There's a little bit of a C thing you can keep an eye out for on that regard.
I'm into it. Hey, so question for you. So, Lisa, Jacob was smart enough, maybe that's not the right word, to bring us to the UGM over the summer.
Yes.
It was a risk. That was a risk. That was a risk.
Walking into the room was a risk.
Yeah,
also.
the whole thing, who knows? But one of the things I think we were both struck by was, everybody talks about, Epic's product first. You guys have all the stuff going on. You embed all the things. You make the platform, blah blah blah. But we were like super impressed at how you loved on your customers, and they like rabidly loved you. Like everyone, because we weren't supposed to talk to anyone that we weren't supposed to talk to, but we talked to everybody. I mean, everybody. Yeah, we were like, hey, what do you think of Epic? Yeah, we got loose. We got loose. Yeah. Rob tried to distract me with the slide. I escaped. But yeah, we were like talking to random people, and they were all like, love Epic, they're the best. Oh my gosh. So what is the approach? This is the actual point to this. What approach do you take to doing research and deciding what to do next? Are you like diving into customer sites? Are you like doing surveys? Like, how do you figure out what to do?
First, that's really kind.
You're welcome.
It's great to hear. And
They could have said, they hated you.
Yeah.
Well, and so I think two things, right? One is you need to listen. You need to ask and you need to listen. And then you need to keep asking because you really want to get down to the root of the challenges that are facing them. The other thing that I think is important is to then really build that into your culture. So one of my responsibilities as a developer, kind of works across our teams, is that every developer has to get on site
Oh, yeah, that's good.
at the elbow
I like that.
of the folks that are using their software, and they need to see it, and it needs to be every year, multiple times a year. Otherwise, you don't. The secret isn't that this is like figures out what you go and program. It's that you learn the challenges, right? If you're programming ED software, it's not about like you need to understand how people flow through the ED. But what's more important is that you walk in and you see the folks right now in the waiting room. They've probably been there for certainly longer than they want to admit, but then you walk through the busy halls and you see the challenges facing the providers, and you walk out the door and there might be a bay of beds waiting outside in case that fills up. And so you start to understand the impact and the responsibility you have as a developer in that context. And so you just have to figure out, how do you build this into the culture?
Yeah.
So, and that's a lot of what we spend time on in that regard. And I think it starts to set the foundation for what I'm glad it came through at UGM.
Yeah.
But I think
they were into you guys.
That's good. We are actually getting the hook. So any
All right.
final words for
Yeah,
our
what was it?
5 loyal
There's at least
fans?
5.
There's at least 5. Some of them are in this room.
well, there's
Yeah, we got a fan
so
in
much
line
more
there.
to do here. So
You can come back on the
thank
show.
you.
We have a real show
We have
that's
more
longer,
to talk
yeah.
about. Yeah, we have more to talk about. There's always more going on.
Yeah, well, you
So-
can, if they let you, if Jacob lets you, you can come on our regular show. You can tell us about the R&D.
We can talk about the R&D.
Yeah.
Jacob, you
All
just
right.
gotta,
Wait, one more
Jacob, you
question.
just see that you
One
need
more
to just
question.
jump right in.
Are you in a band?
I am not in a band.
Because you have like a band
I have
guy
a band haircut, huh?
You,
I have,
what? Obviously.
no, afraid not.
Yeah.
Afraid
Jacob,
not.
come say hello to our loyal fans. We actually really like Jacob.
Cool if you have a handler, is if we get to
Yeah,
show
the
them on
handler gets
camera.
to be on
The camera gets
TV. Come on. Okay, this
Come
is
on up,
Jacob
Jacob.
from Epic. He's actually like super great. Really nice guy. Introduce yourself.
Hi, I'm Jacob.
All right. That's handler right here. All right. Okay.
All right.
Thank
All right.
you.
Take care.
Awesome.
Take care.
All right.
Melissa
Well, we already showed you Michael's handler.
Michael has
He's
the
back there.
same handler as me. Just what a job.
Yeah, what a job. What a job.
I will
Welcome.
not
Welcome.
be handled.
Welcome. You're not-
Hi.
You need to put this on the other side.
Yeah.
You're gonna
Oh my, Melissa. Oh my God, Melissa, can you do anything?
So this
right,
is
Melissa?
Michael. He's the CEO of
Shoes
Arcadia,
on right now.
aka Anisha's boss. I know.
No.
Oh.
I mean,
yeah.
I guess
mean-
technically on paper.
On paper,
Does the
it-
man have a boss?
Does he have? Can he have a boss?
I mean, what? I mean, when Obama was your boss, like nobody else can be your boss.
I feel like
We were recently in the Middle East, Anisha and I, on like an envoy trip, which was spectacular. And literally, like, he would tell these like hilarious Obama stories, including like an amazing story from Air Force
Oh
One.
my god.
And it was like spectacular. And like, God, did people listen to him when he's like, yeah, when I was on Air Force One with Obama, I was like,
And everyone's like,
when
oh,
I was flying
okay.
on Delta the other day and I got upgraded to Comfort Plus.
and I got the aisle seat.
Yeah.
Yeah,
Yeah.
no,
Yeah.
no. I mean, what a presence that man has.
Correct. Do you know that he cares about interoperability?
Oh my God.
Do you know he cares
No,
about both
okay.
fire?
No,
Michael?
you guys stop. So here's the problem. We did have Anish on our show. Anish had told us a lot about fire.
There
However-
was a meeting in the Middle East where he's like, you just need to call Oracle and tell them you want the US certified. I'm like, oh my God.
Okay. Here's the problem, Michael. We did have Anish on earlier. However, Anish did not tell us what the company does. So
Yeah,
he was just like, fire everywhere.
What does Arcadia do?
Yeah.
Why did we do? It's literally nothing.
He was coalitions, getting stuff done. America.
Sorry, I just had a mini stroke.
Very
So you gotta tell us tell our loyal fans what Arcadia even does. We don't know.
I mean,
Arcadia is the leading data platform for healthcare.
That's
So
right.
we work with the best health systems and health plans in the country, folks like Cleveland Clinic, folks like Aetna, Cigna, Intermountain. And we help them bring together all of their first-party data into a single spot, draw tons of insights from it, and through the acquisition of the Care Journey, Anisha's business, we take all of these outside-in insights that we gain from massive aggregated data sources, and we can tell you all about your organization from the outside in. We have provider performance profiles on every single primary care provider, every single specialist in the country on cost, quality, efficiency. Super relevant given the focus on price transparency from the new administration.
The only positive policy news that has come out in the last month and a half, you mean?
I don't know.
Apparently that
I
was,
don't know about that.
Apparently that was controversial.
I'm super excited for my new beachfront resort in Gaza. Come on, I'm on Gaza. It's gonna be awesome.
Well, I was just gonna say, you know, I'm gonna buy some property in the Gulf of America.
Yeah, the Gulf of America. Yeah. My PR guy is. My PR guy is
he knew what he was getting
red
into.
right
He
now.
He's gonna jump over the table.
Yeah, I'm gonna get tackled.
He
He
knew.
wants to see some like PR on CEO violence.
Stop it. Okay, keep going. What do
You're
you
making
do?
jokes about CEO violence.
Oh my
Jesus.
God, Lisa. Lisa.
Wow.
Yeah.
Oh.
Yeah.
Okay. Anyway.
Yes, Mom. No, so
Okay.
we
Really going to hell.
You're going.
so
I'm
we
gonna take you.
bring together we bring out all this data and then we activate it. You know, we have a series of interoperability tools to help acquiring data easier. We have an inbound and an outbound fire server. A lot of our customers, like we presented yesterday at the executive summit with Southwest Health Resources, which is THR and UT Southwestern's JV. We have connected 300 different EHRs, claims feeds on 700, 800,000 people. And like each of those EMRs as a fire server, but if you want aggregated insights about a patient that's navigating in DFW, come to our fire server. And so we're helping, like, as we think about interoperability, we're like the private network part of the TEFCA. And so plus the analytics, plus workflow, plus AI, but we believe in openness. So when you use Arcadia, like our customers get access to every piece of data that we collect on their behalf. So like there's no data blocking. We're all about enabling access and using informatics to transform the way we deliver care.
Great. That was a very professional
Yeah.
answer. We appreciate
We
that.
pulled it
Glad to
That
know.
is the most professional I think I've
being-
been on this show.
After being totally ridiculous and inappropriate all the time, we pulled it together and got one sentence out.
Yeah.
Good job.
No, but let's let's be serious. Okay, so like, what do you do that like makes things better in healthcare? Like what are some outcomes? Like what's going on? Like, are we just like flinging money around? Like what's happening?
Well, those are not mutually exclusive. We are flinging money around. I think some of the things I'm most proud of is helping some of the most at-risk populations in the country get connected with community programs. So the state of California, as an example, state of California,
That's right.
we are working with the Department of Healthcare Services, DHCS,
Great.
and we have brought together all the managed care data for Medicaid in California. So we have 16, 17 million beneficiaries on the platform. That data is being used to identify population-based trends, support the legislature and DHCS in investing in new programs to drive healthcare improvement for those populations. We're bringing together educational data, community benefit programs data, SNAP benefits, incarceration data, so you can get a picture of the patient, not just their health status. And that helps drive like where are you investing, how are you driving better health in communities. That's a big example, but like on a more micro level, you've got customers who are using our platform to identify like where is a patient in need of like care intervention right now, or where a patient's getting lost by the system, and how do you use both agentic AI, also formerly known as robotic process automation.
That's right.
Lol. Screen scraping is just agentic AI.
Agentic AI, otherwise known as I scraped your site.
Yeah, exactly. I mean, screen scraping is like the leading
Interoperability tool.
Yes,
I know.
and facts. Yeah.
It's like facts and screen scraping, and that's like 99%.
And I love the rebrand. Like
Love a good rebrand.
RPA and screen scraping went on Manjaro, and it's like new hot thing is agentic AI.
Oh my God, someone put that out. That's so good.
So
we're gonna put the quote on.
Yeah, exactly.
That's
No,
so
but
good.
but like that's how we're helping. Like we're helping.
That and the TEFCA, the FCA, TEFCA without
Was
the trust. No, that was a guy in a minute. TEFCA without the T is just FCA.
Oh, mine was
two.
Deathka.
Oh.
Some good quotes here. That one's going in the vault though.
Yeah.
Love it.
But no, so like we're helping bring together these data and then activate it to drive changes. We've been doing a lot of work with, we basically have data on everybody in the US. When you think about like the care journey asset plus our own, like a couple 100 million people. And with that like scale of asset, you can draw really interesting insights. You can train algorithms, you can test algorithms. So we're like playing in that space. We just were cited in a publication on like an off-label use of a drug that can then go in front of the FDA. So like lots of fun applications of this massive data set.
Love it. All right, that's good. So you were talking about an example of, bringing in data on a particular population with the state, but you were also saying earlier, helping a particular health system kind of manage all of their data. That actually might go against our friends who were just here from Epic. I mean, not going against them, but, I also think it makes sense for a health system to be in control of its own data from various sources. Is that kind of something that you guys are doing, or how do you think about that?
Yeah, that's exactly. I mean, like, so 70% of my health system customers
should own your own. You should be Epic. The controller of your data resources.
Totally. I mean, like, look, like Epic is a great product. I like pulling data out of Epic because it's generally pretty organized.
Well
organized.
I don't caboodle.
I don't always.
The caboodle. You like calling it the caboodle?
The caboodle.
We typically use another C.
Different
Clarity.
Different C.
Oh, yeah, different. Oh. Yeah, we use Clarity typically.
Clarity,
but also like we're using Kit, some of their APIs. I wish that some of their APIs were more open sometimes, but with El Presidente, he's helped us build some bridges that we didn't have access to before. Which
That's
is
me. I'm
no.
It's me.
I'm the president. Not the one.
I'm not gonna withhold my comment because my handler's here.
My comment.
But no, I mean, so like, but I think that like there are really, really good uses of Epic. 75% of my provider customers use Epic. I have one of my customers is the largest Epic instance in the United States.
Wow.
And they still use us and a number of other data tools because they need to own their own data strategy
Right.
and they need to bring together data sets and have a data model that is broader than just a clinical data model.
Yeah.
And so you start to think about like clubbing together those solutions, and that's where we play.
Right.
All right. So when
I want to say one thing about Epic. We have lots of epic stuff happening on our shows today, and I will just say, like, we would definitely bring Seema Verma on if she would come on the show. We would bring
love
or
her.
if Oracle wants to come, like, no shade, you should reach out.
Oracle does not pitch us.
That new
Pitch
Oracle
us.
EHR product, that like
Oh, the
fully
AI
AI
one.
one, so hot. Oh
it.
my God. I'm like so into it. I told Seema, I was like, I'm so like turned on by this new EHR. It's like exactly what I want to see for healthcare.
Poor PR guy.
My PR guy is covering his face right now.
Is it like super hot?
It's like really sexy. I'm like really into it. I mean, because like here's the thing, Oracle like
I rebuilt my EHR.
well, here's the thing.
Well, sometimes you gotta just make things
they were
new.
just like, they're like, boom, reset button. We're gonna reel it from the ground up, and it's amazing. I mean, you think about
Blow it
the
up.
resources that Oracle has. They're like what, like a 10 times, 5 times, 6 times bigger company than Epic. They're massive. Like to me, like the biggest threat to the industry for like small vendors, mid-sized vendors, it's Oracle. Like they have like real FU money, and like and they can really be disruptive with it. Hot take. Oracle's the one to be afraid of.
I mean, I didn't know they were so sexy.
They are super sexy.
Yeah, I'll
I
say.
mean, have you seen? Well, again,
I
PR
knew where
guys
you
here.
were going, and I was going to finish it for you, but I'm not going.
Tell them finish it.
Because
The PR guy's right here.
Anyway, that's exciting that they're so sexy. They should focus more on how sexy it is as opposed to the weird blogs that they're doing. Yeah.
Oh, I lived for the weird blog.
Okay, but it's
I mean, our text thread was so on fire on that blog.
okay.
It's been a long time since we had like so much activity on our text thread, which we need to bring life back to it.
Just to be clear, obviously on this show,
Can we move it to Signal?
Sure.
Thank you.
Or Telegram.
I like Telegram. That's where I get all my information.
That's where I was on January 6th.
Telegram was the question.
Anyway, the point is, I have a question for you about Arcadia.
It's like giving
I-
us the hook
I think our
because
next guest is
you're safe
freaking
here.
out. He's like, oh my God, what's going to happen? Okay, for real. So when a health system uses Arcadia, who makes less money?
Yeah.
Because your product is doing stuff.
I think like a lot of point solution vendors probably make less money because we drive consolidation in
Wipe them out.
tools. But I think ultimately, like it's probably people who are delivering unnecessary services, like that whole like urinary catheter thing. Like Care Journey was a big part of finding a lot of that. Do you like urinary catheters? Like that's uncomfortable.
Urinary
Scott,
catheters There's
I-
the big Medicare.
Behave.
It's a huge
We got-
fraud waste.
I just want to say we got a lot of handlers in the
Yeah,
room
yeah,
today.
yeah.
And anyway, okay, Michael, one more thing for our loyal fans. There's at least, like Lisa said, several of them are in the room today. So
Yeah.
it's probably
Is
only a
anybody
few.
watching this? Because we're all here.
Yeah, all our entire fan base is in this room. No, what do you want to tell our loyal fans? What amazing thing. Hot take.
Hot take. One amazing thing.
Well, I mean, we learned that RPA
Went
got on
on
Manjaro
Manjaro,
and is now, yeah, and we learned that the Oracle EHR, the new one, is super sexy.
I don't. Those are my hot takes.
Okay, those are pretty
Those are my
good.
hot takes.
Those are pretty good. Yeah.
I'm long on Oracle right now. Like I'm like pretty impressed.
Oh.
I'm kind of like I gotta tell you, like I'm like kind of like really interested to see what Miss Gleason's gonna do.
Yeah.
That's my
yeah.
other hot take.
Yeah.
I
So
love
we-
me some Amy Gleason.
We are Amy Gleason fans.
I'm
We
an Amy
highlighted
Gleason
her on our
fan.
show. We think
I-
she's gonna do good stuff.
I think she's doing good stuff. She's smart. She's intelligent.
Yep.
I don't know. Like I'm choosing to be bullish on Amy Doge.
Yeah. Amy Doge. Amy's gonna
Can we get
Doge.
shirts made?
You know, I think we can.
I love that.
Okay. Yeah, I think we can.
No laws or rules.
We don't follow laws, so I'm sure we can do that.
I never followed laws.
Shut up.
And with
Oh
that,
my god.
And with that,
This poor guy.
CEO of
Oh my God.
Arcadia
Yeah.
is out.
Goodbye.
goodbye.
Bye. We love you.
Okay. All right. We got
You've been through so much today.
yeah.
You've been through so much.
Welcome. Are you terrified?
I am.
Oh.
I am. Like, am
So-
I prepared for this?
So we got Zeomega. You're not prepared, Scott? Did you not prepare him? We have a lot of handlers. Scott, come say hello to our loyal fans. They like to meet their sources handlers. This is Scott from Aria. Here he is.
Hi, everybody. It's an
Hello.
honor to be here with this.
Are you terrified?
I am. I'm terrified on behalf of Suhas, and I just hope that
Yeah.
urinary catheters don't play a large.
They might. We'll see what happens. So,
I couldn't stop laughing.
Suhas, welcome to the Health Tech Talk
Thank you,
Show.
Thank you.
So we've been interested in Zeomega for a while because you guys have been around and you work with a lot of payers, and like, not sure you've noticed, but like, shit is crazy in CMS land. So, well, introduce yourself first.
Sure. Well, thanks for having me to discuss this critical topic.
Urinary
Um,
catheters.
Yeah.
No,
so
wait,
I'm,
Just kidding. It's a bad joke.
Yep. So I'm Suhas Ramachandra, the Vice President, Product Strategy and Innovations. I've been with Zeomega for 20 years.
Wow.
One of the first employees here on the state side.
Wow,
So I've pretty much aged with the product,
Love
evolved
it.
with the product, and I love what I do. And I drive product strategy. I oversee product partnerships as well as lead engagements with research organizations like Class and Gartner.
Love it. Well, I see you are wearing a best in class
Best in class.
button.
For 4th year in a row.
What? Awesome. Okay, so tell our loyal fans what Zeomega actually does.
The Zeomega is a leading care management and population health management platform company. And we've been in business for the last 24 years. And we cater to about 43 plans in the US, with close to 43 million lives being care managed. We have a very diversified portfolio of customers ranging from commercial, Medicare, Medicaid, ACOs, TPAs, health systems, or payviders. So, yep, and
Love a
we're going
payvider.
strong.
Yeah,
Yep.
that's awesome. Yeah, I mean, you guys have been around for a while. I know we've like always heard about Zeomega in the world. So what do you guys think? Like, what is going to go down with your business in the new administration? Like, are there any big changes you guys are looking out for? What's going on?
Not really, but I hope I had a crystal ball, trying to think what CMS is going to do with changes in Medicare specifically. But it does appear that Medicare Advantage is going to trump in terms of priority and regulations.
Yeah, that's what we've heard
right?
from our inside
So-
sources.
Yeah,
Sometimes we make up those rumors, but I believe that one's a true
This
one.
one's a real one.
It's
I
a
think
real
it's
so
a
you
real
have
one.
the crystal ball that I need
Yeah.
to borrow.
Well,
Okay.
It's not really a crystal ball as
More
much as
like
it is
a
a.
board and sometimes
Yeah.
things on the internet.
Well, I mean, there was as you know, just thinking back in history, I was reminded of this. Of course, Medicare Advantage was already cut, so to speak. Back when the ACA first came out, in terms of the premium paid on top of 100% of
Uh-huh.
Medicare fee for service, And, moving forward, with some of the programs that were introduced previously, they also kind of continue to bring those margins down and down and down. Like, how are you looking at that? How are your customers, your partners thinking about that as well? Because you can imagine that if you're going to see any savings, you got to tighten that up further and further.
Well, that might be an opportunity, right? Because you
Yeah.
need a system that's going to help
Yep.
you do shit.
Can't just do it on vibes.
And the
Can't
thing
do it on
is, for the last 20 plus years, we've always focused on automation. I must say that we are one of the first care management platforms to build a very sophisticated and flexible rules-based engine. And our 40 plus plans who have Medicare Advantage lines of business are already benefiting from using these rules engine and accommodating all these policy updates and whatnot. Well, the new fever is AI. When you say automation, are you doing anything with AI? Are you doing anything with Gen AI? Yes, we are. And how are you leveraging Gen AI? Is basically converting custom policies. So today plans actually have PDFs for custom policies.
Yeah.
And they have to manually create, questionnaires for providers to kind of fill in. But how about throwing in Gen AI to handle that conversion automatically and auto-populate the data using NLP OCR from the EMR? So that
Seems
is
good.
cutting-edge technology and automation that MA plans can leverage because you are optimizing resources at that point. And Medicare Advantage is all about resources, staffing, reducing admin burden, operational inefficiencies. And we have the tools. It's not that we're building these tools because there's a new administration, but we've always thought that as a product strategy, saying the government lines of business should always be equipped with tools to adapt to changing needs.
Yeah. Well, I
So-
mean, I think MA in general is really, really, really being pinched also for other reasons, including that because they have put in place so much prior authorization, they are now getting dropped from various providers. Like providers are starting to say, no, actually, I don't want to be part of this. And that was kind of a no-go area in the past, right? Nobody wanted to not take Medicare patients or Medicare beneficiaries. And the tides have turned. So I imagine the pressure to reduce those admin costs is probably massive right now because they're like, we are getting kicked out of networks.
Yeah. And I think well, I'm sure you're privy to the CMS interoperability and prior authorization rule.
Yeah.
Now that rule, once effective in 2026, is meant to help providers to reduce the provider abrasion, because I mean the goal is to be transparent in terms of why are you denying an authorization?
Right.
You're supposed to respond to my requests for half the time for what it used to be, like 14 days versus 7 days. And the most important thing is standards-based exchange, data exchange between payers and providers. As long as these mandates stay in effect, and the providers are going to win. End of the day, Medicare Advantage is not going away. It's part of the ecosystem. It's how technology and investments would bring payers and providers together and write these contracts saying, let me exchange data, let me incentivize you, and you know what, things will fall in place. It's just a matter of time.
Yeah.
Okay. What do you think of just abolishing prior auth?
Abolishing
Should we just
prior auth.
get rid of it?
Well, I wouldn't say abolishing, but it's possible that if value-based care really pans out to be a successful shift, you may see prior authorization in the eyes of, should it be outcome-driven versus a transaction? Today, it's more of a transaction. And I need to respond in 72 hours. I need to talk to the provider for more information. So it's very data heavy to render a decision using MCG, InnerQual. And I think that perhaps will slow down in the future and you will move more towards, can I auto approve anything that's low risk and just spend the complex cases, a high cost procedure to be looked up by an AI, but maybe have a human intervention? So
I mean, that's what AI enables you to think. Hey, you can do this more creatively. I'm going to do that 80% of the job for you. And remaining is just a human sitting there, check, 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 and it goes through. This is where Zeomega is saying we're just not using AI as AI. We factor in explainable AI for what this decision entails. So what are these 5 things that leads to this decision? So you don't have to go back and dig into the
Try
data.
to figure it out.
So
Yeah. It's interesting that there is even like that it makes even financial sense right now to deny low risk and relatively low cost procedures. But you have this future that's been painted for us of like agentic AI on either side of the equation, kind of fighting each other. Like, how do we avoid that kind of sort of dystopian future?
It's again, my experience has been payers are willing to come forward to pay for tech for providers to use, which means the payers get to see what the providers part of the is. The providers get to see what's happening on the payer side of the
Yeah.
So when you streamline technology to be the same platform, yes. But if you use, sorry to say, Epic or their solutions on the provider side, which is very predominant, and you use a care management, if you need to have 2 systems talk with 2 different types of data, that's where that leads to confusion,
Fighting
right?
that, yeah.
But if you create a convergence between payer and provider ecosystems, establish partnerships, and there has to be a win-win situation. The payer will need to tell the provider what happens with the patient. At the same time, the provider will need to tell, provider will need to tell the payer what happens when in a visit or whatever, right? That handshake will happen. I know it's pretty ambitious, but I'm confident it will happen because providers and provider-owned health plans know that it's important for this to happen. But data sharing hopefully will solve a lot of the problem. So
Yeah. So question for you, just in general on product strategy, because that's cool.
Yeah.
Right. And you've been around, you've been doing this a long time. So what's the big exciting thing you guys are working on next? Like, are you releasing anything here at HIMSS? What's the big exciting news?
There's so much.
Love it.
I'm just thinking where I start. So care management for us has always been about business process management, CMDM, appeals, dashboards, regulatory requirements. Our goal is to see how to help plans optimize their resources. I'm never going to say AI is going to replace humans, but it will help you optimize. You talk about Medicare Advantage, and I see 2 critical components, the MLR and total cost of care. If I can save or keep the MLR to an 85%, there are small Medicare Advantage plans that can run the entire operations at 15% of admin costs. But today it's peaking anywhere between 89 to 92%.
Yeah.
So what can I bring to the table to help these plans bring down that MLR or keep it at 85%, as well as how do you keep the cost of care below, which means I need to really tell which intervention is causing the leakage when it comes to the overall cost. Now, it's just not the payer, but the payer can tell the provider, because they're running their ID stratification algorithms and whatnot, saying, maybe you can look for alternative care for this patient. So, so keeping all of this in mind, Zeomega is focused on the medical policy automation. We are expanding a partner ecosystem to bring in OCR NLP solutions so that we handle unstructured and unstructured text to structured text, auto-populate the data so that the nurses don't have to find where the data is. We have new solutions that we've launched for member engagement. And again, in the context of quality of care or HEDIS, we exactly know which intervention will need to be prioritized for that member. And we also have social determinants of health to say, this is really a transportation issue. So we partner with transportation vendors and we can hand off the intervention so they finish the last mile in engagement. But if you see, we are trying to automate everything in the value chain.
Mm-hmm.
We're not basically saying, I'm done here at 50% and a handoff. Interoperability, that's key, because we have, back in 2015, I don't know if our founder CEO had this future sight about all the value-based care and whatnot. So we acquired a company called Health Unity, and they're an HIE company. So we've been able to leverage the assets from that company, and we now have a smart authorization gateway that we've been able to develop and orchestrate decisions agnostic to any care management platform out there. So that's the interoperability. I mentioned to you about AI, Gen AI, member engagement, and lastly, provider engagement. On the payer side, it's not been very traditional to handshake with EMR platforms, saying, can you connect with Epic or an Athena or whatnot? So we've not really ventured into that space.
Yeah.
But now we've begun to. So we've now established a partnership with one of our partners called Hold-On Solutions. And they're an EMR overlay. So we are now able to orchestrate insights from the payer, real time, to the point of care, but everything subjective to the contract between the payer and the provider. So we are able to adapt to those contractual arrangements, and we personalize the technology stack to that arrangement.
Nice.
So
Awesome. We are almost getting the hook, but do you have any final words for our
all of them? They're all there.
Remaining
On the
loyal
internet.
fans.
yeah, so I think as long as payers adopt to standards-based exchange or a trusted-based data exchange and put trust in automation, again, the belief is you don't have to invest in building native AI solutions because you are a custodian of your own data. But it's good for them to experiment and evaluate AI solutions with existing platforms like Jiva and Zeomega. So we have all the hooks within the ecosystem that we can turn on right away. So that's kind of a best investment and a time strategy that payers can benefit. So.
Love it. Love it.
Okay.
Well, thank you. This wasn't that awful, right?
No, it was fantastic.
Great.
Yeah.
Oh my gosh, no one even got hurt.
No one even got it.
No one even got hurt.
Thank you very much.
It was a pleasure to meet you live on the
Likewise.
internet.
Thank you.
Here we are.
Your damn all right.
All
Handing
right, we got our last guest of HIMSS25, repeat guest and super fan.
Did I just shut this off?
Oh no, it's on. You're good. You're good.
Okay.
You want to hold it,
ladies?
Hello, welcome
Okay,
to the
I'm
show
glad
again.
I'm glad I'm like in the afternoon because I did not follow the instructions last night.
Did you not eat either? Me neither.
Yeah.
It was
Okay.
rough.
It was wrong.
OMG.
Thank you for
Also
later in the
proof that
day.
we do have
So-
women on the show. We try.
I
Unfortunately, there were a lot of men at HIMSS, and they all came on our show.
I know. Am I the only woman on the show this time?
Yeah.
Grim, right?
We
Okay.
maybe
I feel
fucked it up a
honored.
little bit.
That's okay.
Well,
That's
no,
okay.
well,
No, I actually
You
saw
count
someone.
for at least 4.
Yeah.
So,
Thank you. Thank you. And I did hear someone this morning like walking around like it's a total bro show, right? Like
Okay,
it's
so it
men
kind of
everywhere.
is.
So
No, I also do
All
you
the men, all the men have left
okay.
the room now, so
Yeah,
we can say whatever.
there's only women in this
Okay.
room. We are 5 women. It's
there we go.
all the
All
time.
right.
Okay, but do you not think we were talking about this earlier when we did approximately 4 minutes in the exhibit hall? HIMSS is like back.
HIMSS is back for
Like,
sure. Except
back.
for, did you guys do the hike to like the interoperability
No.
showcase? which is,
Absolutely
like,
not. I don't even
way
know where that
far
is.
in the corner.
Why
I
would
was
they put
like,
the interoperability showcase so far away?
it was so far away, and that's why I'm presenting tomorrow. I'm like, okay, I have to like walk a whole mile, which was fine. But
Okay.
anyway,
you might-
fun
you
party
might-
last
yeah,
night.
so you might need to.
That was a great
actually
party.
Introduce yourself.
Yeah,
Oh,
yeah. Tell our loyal
yes.
fans.
Hello,
I know there's only 3
There's-
because you're
right.
here
I'm
and
here.
we have a live audience member. But
So Pooja Babbrah, I'm the Executive Vice President of Strategy and Industry Alignment for NCPDP, and we are a nonprofit, so I don't have a handler. I am
Love
handling
it.
all the media myself.
Even
So
better.
love it.
yeah,
Although,
yeah.
can we
So
talk about how again, being Michael's handler would be awful.
right.
Yeah.
Well, I saw even Anish had a handler this morning. So
It's the same
yeah.
guy, unfortunately.
Yeah, it's the poor. It's the
It's
poor guy.
literally his
He's like-
job. He's So
bring everyone.
it's not
Yeah,
nonprofit
yeah.
people, no handlers.
No
and,
handlers.
but that's
Yeah, we
fine.
can handle it
But,
ourselves. Yeah.
So Pooja, you've been at NCPDP for like a year.
6 months.
Only
Not
6
even
months.
been-
Oh
It
my
hasn't been a
God.
year.
Okay,
Hasn't
so
even
the
been a
great thing many of our loyal fans will know is that Pooja is kind of like when we don't know stuff about like pharmacy interoperability,
anything about
we
pharmacy
shout out, we're like, where is she? And
Please
sometimes
answer our questions, Pooja.
sometimes because she has a real job, she's not always live commenting the answers. So but she is the person we ask all the time. And so
Which I
yeah, so like
love.
so
Thank
what's
you.
so what's going on? Because like, you know, we got this new administration, like we don't
do.
know what's gonna happen. Like, do you think pharmacy interoperability is going to still be like a priority?
I think it will be. And I have to laugh about Anisha's whole like the Maha thing because, okay, hear me out, hear me out. I am also reaching across the aisle on this, but the whole chronic care management, if you think about it, pharmacists do so much, right, for chronic care management. So if that is truly coming back, that gives pharmacy an opportunity to do the things that they do best, right? I mean, there's studies out there that it helps, you know, with hypertension, you know, if they're following patients. So I truly believe that pharmacy interoperability will be a thing. We started doing stuff under Sequoia Project with pharmacy interoperability. So, you know, depending on what TEFCA, what happens with that
EFCA.
the EFCA. But I do think no matter
We're really
what,
spreading that one around today.
I love it. I was cracking up yesterday when they said that. But so here's my thing with NCPDP. We decided that no matter what, right, having the physician be able to exchange clinical data is important, whether TEFCA's there or not. So that's the support that we're going to give. We just did a new strategic plan, and it's all about clinical data exchange for pharmacists. So if it goes away, whatever it ends up being, you know, it's still going to be there. So yeah.
Well,
100%.
I went down a whole rabbit hole about the situation currently for retail pharmacy
Mhm.
and have been enlightened quite a bit about the pressures on retail pharmacists. So maybe if there is a real pathway, maybe there'll be some payment for it and they could consider hiring some more people because those retail pharmacists and all of their pharmacy techs are like, it's unreal what they
Yeah.
have to do every day.
It's crazy.
Unreal.
And they're still just only getting paid to dispense
Yeah.
meds, right?
Yeah.
So until we actually have payment models
Right.
or if health plans decide that they're actually going to reimburse for it, which I think they should,
Right.
or providers, right, are able to do that, I think that's what they need to be able to do. But 100%. And part of the problem is we have to get them being able to be paid to do this stuff. So,
Yeah.
which comes back to, right, the clinical data exchange. So we need to be able to tell people what they're doing and get paid on it. So, you know, NCPDP is supporting all of that and trying to drive it forward. So it's fun to attend these things now because I don't have to sell. I can just be like, I have a great idea. Why aren't you thinking about pharmacy? And it's amazing, right? Like the health plans are like, oh yeah, we should think about pharmacists. And you know, the providers are like, we love pharmacists. I'm like, well, your association doesn't say that, but okay, but they do. I mean, doctors do love pharmacists. So
Yeah, doctors do love pharmacists.
So,
So what else are you excited about at NCPDP?
So we are starting a pharmacy product locator pilot. So one of the big things we heard, so high tech, I know they're on pause, but did great work, right?
On pause or canceled.
On pause or
We don't know.
canceled indefinitely.
Yeah.
TBD.
TBD, but they, you know, we made recommendations, right? From the high tech committee to ONC. ONC came to NCPDP and said, we want you to move some of these forward, some of these recommendations. So one of them we heard loud and clear from patient advocates was, we don't know if the pharmacy has my med, right? And they end up calling around like 7 different places. So ASTP ONC gave us some funding to do a pilot. So we actually kick off in 2 weeks, and we're having pharmacies participate. And so doctors, when they go to prescribe, will be able to ping the pharmacy to be like, hey, I want to prescribe this med. Do you have it? And then if you think about it, the whole price transparency that's coming back, it's like, do you have it? And how much is it?
Charge for this thing.
Yeah. So, you know, which will
cool.
be great. So I'm excited about that. And now we need to get it in the patient's hands because we know doctors don't have time, but yeah, baby steps, one step at a time. So
There are people doing work in this area, right? A long time friend of the show, Otto from Photon is doing its
Otto
work
and
there,
Stu
right?
photoning it up.
So breaking news, Otto is they are going to participate in the pilot. So super excited.
Man,
So
we freaking
we're
love
going
those
to have them on
guys.
our podcast
Oh my
in a
God.
couple months to like find out the learnings. Yeah.
I will say
It's not
that-
him. It's I think
Stu
it's Divya or Dia.
Somebody
I
else.
think yeah.
So I mean, last night Otto was being very ridiculous, and he was describing his company as a lifestyle brand, which it is not. But he would not elaborate further.
I think he wasn't
like,
eating either.
Lifestyle.
That's the
brand.
problem. I didn't follow my own
was- I
rule.
did.
It was really difficult. And
It was. It was definitely
got uninvited to my
definitely.
party. So sad.
But
Yeah.
you know, it's interesting to see that there is we're starting to see little tidbits of innovation pushing through in this area, right? Big unexplored.
Yes. So we've for a long time, I think we've had kind of big corporations, right, in
Right.
the space, and now we're starting to see photons, even Amazon Pharmacy. Amazon Pharmacy is going to be participating, right? And so you get
Wow.
these people that are like, hey, we're
Yeah.
interested, and we'll get
That's
people to
awesome.
follow along. So yeah, so we're finally
Everybody wants to be on a team that's winning.
exactly. So pilot work and beta testing, and then hopefully scale nationally is what we got to do.
It's
So.
actually interesting because the retail pharmacies are like suffering so much and have had so much turmoil in their businesses. It kind of pushes or allows these opportunities to rise up because people say, well, we can't do the same thing. Our core business is struggling. What else
Right.
can we do? Like it gives very difficult for people who worked at Walgreens or CVS or were
Yeah.
involved in those things, or Rite Aid, which I think still exists.
They do.
They-
I'm meeting with someone tomorrow.
Wow.
Right.
There you go.
Yeah,
There you go.
exactly. There you go.
But this is like how you could open up to sort of new
Yeah.
ideas and new innovation when the business model fails sometimes,
Yeah.
as it does.
As it does.
Sometimes it fails.
No, but so what's wild to me is like, why, I always think about, because I love capitalism.
Mhm.
I'm into it. And I'm always like, why are certain things not happening that are so logical? Is it just because of lack of reimbursement? And like, why are pharmacies like living out here in the
Yeah.
wild?
Right,
Well,
by themselves.
Yeah.
yeah. I mean, it
eating
truly
scraps,
is.
like-
Yeah. I mean, that's part of the problem, right? Is I think the business models. So I'm going to comment just personally, not under my company, but we
This allegedly happened.
this allegedly happened. But, also we need to be thinking about what we did with the payers of opening up and being transparent, right?
Mhm.
And so that is a big thing. And so we got to get away from this, pharmacists are only paid a certain amount of money
Right.
for dispensing meds and all that.
Yeah.
And so I think there's just a lot that needs to change. I think with this new administration, we might be seeing some of that. But yeah, it's unfortunate because I think pharmacists do great work. And then, it's like they're closing left and right. I mean, we have data at NCPDP that shows all the pharmacy closures and,
Mhm.
all those articles that you see coming out about
Yeah.
pharmacy deserts. It's all the data we're collecting on who's closing shop, which is
Wow.
unfortunate. It's all the community pharmacies. So.
Yeah.
Dare I say, and this is totally my opinion, just to be clear, dare I say that we need site neutrality for services that pharmacists can also provide?
Yeah.
Site
100%.
neutrality, Kat?
I like that. But I
That
do.
makes
we do.
sense.
Yeah, no, I mean, that makes sense.
We do.
It totally makes
Totally makes
Well,
sense.
yeah, I
Yeah.
mean, I totally agree. But what was I gonna say about just like pharmacy stuff in general? So like the whole MTM, like it's all bullshit, right?
Well, no, that's the one thing they get paid for. So
Who was
we
telling
can't
us it
take
was
that
bullshit?
away. But
Was it Clay Ferris? I don't know.
yeah, I mean, they still do MTM, but I would love to see models coming out where pharmacists are just part of the care team. I mean, that's our whole push, right?
Are there
Like,
any
think of the
CMMI models
pharmacists.
with pharmacies as?
I think there's a primary care one,
Yeah.
maybe, but if
We
you
should
remember,
call Abe Sutton. We should call that guy.
we should call
We
that
should
guy, but
call
I
him.
don't. Is CMMI even
So
around? Like they
Abe-
hired a pharmacist.
No. So Abe is, as we understand, the incoming director of CMI. Abe, you can definitely come on the show. We
Come
would
on our show.
love to talk about it more. We would love to
Yes,
talk about it.
yes.
Yeah, we would
and,
love to talk
and
about
think
it.
about
Make a
pharmacy
pharmacy would be great.
models.
Yeah.
Yes,
Yeah.
100%. I bet it would work.
Well, the thing
I
with the
know.
problem,
America would save money.
the pressure is that you said, of course, is that especially independent pharmacies are closing across the country,
Yeah.
and those are the places where like there isn't another provider of care in the community that
Yeah.
would be really great because they you know, exist as this sort of hub. Everybody, at least until recently, had to like go in and get their meds or whatever, and then could have an encounter with a community pharmacist. But that's it's these are closing because there isn't as much of a business model anymore.
Right, exactly. Well, and then the other issue is all the pharma or the provider shortages that we're having. I mean, if you think about it, in the rural areas, you may just only have a pharmacist, so let them do some of that work, right? And actually reimburse them for it. So
Well, that's a good point. You know, I spent a lot of time in West Virginia. Hang out there.
Yeah.
And that I'm fine. This is exciting. Oh my God. Anyway, so you know, one of the big success stories in the early days of distributing the COVID vaccine were like these community pharmacists would like drive around and did all that work as people knew them, and like that's what's so sad. But isn't West Virginia, don't they have like the highest number of independent pharmacies or something?
I think they
Like
do.
that?
I think they do. Yeah, they do. I mean, there's just so much, even maternal health, right? I mean, you know, making sure that mothers are taking their meds and their vitamins and, you know, all of that, right? Like just help, you know, there's so much they can do. So
I totally agree.
Nice.
I know. I know.
So what else? Tell us about, you know, why you were here beyond getting to just experience and have
be social.
Bro time.
Bro time.
I feel like our party had an even distribution of ladies and men.
And I finally got to meet. Darshak and Shuchi. Oh my God, we totally. I did not. I did
Shuchi,
not.
Rana.
I may have, but I think I left. I feel bad, but I think I left the party early last year because I was presenting like the first thing the
Pooja,
next morning.
you did meet Darshak because you were yelling at him for some reason that I got invited to Anisha's Indian after party.
Oh yeah.
And then he was like, wow, I don't think she likes you. I was like, I think she likes me.
Okay, I obviously did not eat last year.
We're gonna make Melissa cut the feed soon.
We
but
are.
Give us your final.
So
that was a great
So
party.
the other thing that we're doing, Sequoia project, under the interoperability matters side, not on the RCE side. We kicked off a pharmacy interoperability work group. So
Awesome.
you know,
We
just
saw that on the
talking
internet.
about-
We did.
Yeah, and so like, hey, like what do we need to do, right, to get pharmacists onto TEFCA and doing all that. So, that's the other thing I'm like going around telling people, like, come join us.
How do interested stakeholders get involved?
Go to the Sequoia project and look for pharmacy interoperability work group.
That's right.
Yeah.
Or DM Pooja on the internet.
Or DM.
She's there.
Yeah, I'm there.
She's around.
I'm there.
She
Well,
has a
thank
little
you.
more time now,
Yeah.
but
Our
she's in a
favorite
different role.
pharmacy expert.
That's right.
Yeah, we
The
need
one
her.
we always ask to
The one we always ask to answer.
I'm still there.
Audience guests, you should come. We gotta get up here. Just look on the. We have like a live audience of
We
one
do.
person. So good. Oh my gosh. Here she is. Here she is.
Jump
Here.
in, jump
Introduce yourself. Hi, I'm Jen Thomas. Thanks for letting me
Yay.
join.
What do you do, Jen Thomas?
I had a customer success at a health tech startup called Candor Health. We're focused on provider data.
Oh,
are you familiar?
I mean, I've heard of it.
Maybe. Awesome.
Yeah.
Yep. So, here learning about interoperability and how we might be able to help.
Do you love pharmacies?
Yeah. So actually, I used to work at Michigan Medicine, and I was working with a researcher that was focused on building a new model with clinical
Nice.
pharmacists.
Oh,
And substance
Michigan did the CDC thing where they were actually managing the hypertension for patients, and it was so good that they started to spread, like actually do it in other states.
Yeah,
So
awesome.
yay, Michigan.
I'm a
We
big
love
fan
Michigan.
of-
Yes.
Look at how
See,
look at how
connections.
amazing our audience is. The people who watch
I
the show
know.
are winners. They are great. They A+.
Real Americans.
That's right. Most of the time.
And women doing great things.
Women doing great.
Right.
That's
Yeah.
And we met at lunch at the bar, so talk to strangers, people.
Make new friends.
Point is make new friends.
Make me friends.
All right. All right. Melissa's gonna cut the feed. Melissa is losing her mind. We love you all. We will not be on Friday. We are off, but we'll be back the next week. And so talk to you all soon. See you later. Thank you. We're done.